Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Well, Tracy, as you know, you can get cancer pretty much anywhere in your body, including the eye. And there's a tumor called retinoblastoma that is the most common form of cancer affecting the eye, mostly in children, although it can occasionally occur in adults. And it can occur in one or both eyes. Now, it begins in the retina. That's the light-sensitive lining in the back of your eye, sort of like the film in a camera.
It senses the light that comes through your eye. Yeah.
Yep, right the front of the eye. Exactly.
Gotcha. Today we're going to learn more about retinoblastoma from two Mayo Clinic experts, ophthalmologist and ocular oncologist, that's eye cancer specialist, Dr. Lauren Dalvin, and neuroradiologist, Dr. Waleed Brinjikji. Welcome to the program, both of you.
Thank you so much for having us.
Thank you very much.
Dr. Dalvin, unfortunately, cancer of the eye that affects mainly children, retinoblastoma. Tell us more.
Yeah, so this is the most common eye cancer that we see in children that actually starts in the eye itself. And this is one of the most common things that I do in my practice. It's something that often the parents actually pick up. So it's something that sometimes doesn't necessarily get seen by our pediatricians if we're not having routine dilated eye exams. So often we find this most commonly with mom, often noticing a white reflex in one of the eyes, either just looking at their child or taking a picture. And actually our second most common person who picks this up is grandma looking at their grandchildren.
So the pupil looks white? Is that what it is?
Yeah, that's right. So oftentimes if you notice on camera, or back in the day, if you think to before we had cell phones, you would get this red reflex in the eyes. So this we're seeing actually a white reflex. You can see it when you take a picture. You can see it just kind of on glance at an angle. If the light shines into the eye and hits this tumor, it's actually a white tumor, so it creates a white reflection.
Why does it affect children instead of adults?
Yeah, so this can be actually in some cases inherited genetically, where there's a specific mutation on a specific chromosome, chromosome 13, that can cause retinoblastoma tumors to form as the eye is developing. But this can actually occur sporadically as the eye is growing in a child. Even before they're born, sometimes you can get little mutations that the immune system isn't able to fight off that can develop into this cancer.
So by the time you're an adult, that's less likely to happen?
Correct. So by the time we're an adult, the eye has mostly been formed. We don't have rapidly dividing cells in the eye anymore, so we're much less likely to get any mutations in the retinal cells.
So most of these kids are how old when they're diagnosed?
So when we have our genetically inherited type, or when we see it in both eyes, then usually we pick it up by about a year of age. But most cases actually are not this inherited type. They're kind of that sporadic, just some funny mutation happened during cell division. And that's usually picked up about at age 2.
And
Now, because this is cancer, it can metastasize and actually take a child's life.
That's correct. We're really fortunate in the United States. That is very rare. We're lucky that we tend to catch this early. But this can travel usually down the optic nerve toward the brain, and it can spread to other parts of the body. And once it gets out of the eye, it can be very challenging to treat.
So the optic nerve is the nerve that carries the signal from the back of the eye to the brain.
Exactly right.
Okay. So is that where it goes next? As it goes to the brain?
That tends to be, if it gets out of the eye, that's how it spreads back toward the brain. And actually, our children who have the genetic form of this also are predisposed to a specific type of brain cancer that happens in a specific place called the pineal gland. So they can get a pinealoblastoma, and we have to watch that with MRI scans.
Wow. And so if you're able to, let's go back, just take a step back, where it hasn't traveled outside of that eye, can you save the eye? Or if a child has this in their eye, does it have to be removed?
Great question. So I always like to discuss these 3 main goals of care with any family that is affected by retinoblastoma. So our first and foremost important goal is to save the child's life. So we always have to keep sight of that. But our second goal, if it's safe, would be to save the eye. And oftentimes now we really can. We're getting better and better at that. And actually, Dr. Brinjikji here with me does something called intra-arterial chemotherapy. And so for some eyes that have really advanced tumors, we can now save them with this technique, where before we would have had to remove the eye.
Let me just ask you one quick question before we go to, we can call you Dr. B.
That sounds good.
So once it's suspected by the mother or the grandmother that the child has this, how do you confirm the diagnosis? What do you do to say, oh my gosh, this is retinoblastoma?
So most often we diagnose this based on our clinical exam. So the best thing to do is try to get a good dilated eye exam. And oftentimes a local pediatric ophthalmologist can help do that. If the pediatric ophthalmologist is concerned for this, then they'll often send to an ocular oncologist, someone who has special training in eye cancer. And we can do things like an examination in the operating room with the child asleep. We can take a careful look at both eyes and do specific tests like ultrasound to look for calcium, which is common in these tumors. And we'll often do an MRI scan, not only to look at the eye, but also to look at that part of the brain that may be at risk.
So tell us, Dr. Brinjikji, how you treat the children. What are the newer, better ways?
Yeah, so over the course of the past decade or so, there's been an emergence of this use of intra-arterial chemotherapy. And essentially what that entails is taking a tiny catheter, which is like a hollow tube, and the size of that tube is about 1/3 of a millimeter in diameter, so really tiny. And you go from the groin all the way up to the blood vessel that is right behind the eye, called the ophthalmic artery. So it goes, basically into the retina that we had talked about earlier. And then once you have your tiny catheter parked in this ophthalmic artery, you can deliver the chemotherapy agent directly into that artery and then directly into that tumor.
Get out. That is amazing.
Amazing. So that's instead of giving it systemically, intravenously, where it goes to the whole body, you direct it just to the eye, just to where the tumor is.
Exactly. And that's nice because it avoids giving, what's called a systemic dose. So a dose that would affect all of the organs in the child. You can give a smaller dose and then target it directly into the eye itself.
That's amazing. How effective is it?
So it depends on the size and the extent of the tumor. For some of the smaller tumors, the efficacy is well over 90%. But then for some of the larger tumors that we've treated, the efficacy is in the neighborhood of about 50 to 60% in terms of preserving the eye. In terms of allowing us to preserve the eye itself.
And how often does the eye require removal? How often do you have to do that when Dr. B can't save it?
So it's less and less all the time. So really, when we catch this tumor very early, we kind of classify these into A, B, C, D, and E. So when we catch it early at the A, B, or C stage, we can save nearly all of those eyes. If we get into our Ds, maybe about 1/5 of eyes have to be removed. And when we are at our E's, which are really our most advanced eyes, still about half of those eventually have to be removed. It's not necessarily always because we can't control the tumor, but sometimes the tumor's so large that it's made the eye sick, even if we're able to cure the cancer.
And if this treatment is successful, is vision completely restored, or do most kids lose some vision?
I would defer to Dr. Dalvin on that one.
So we can have a pretty wide range of visual acuity outcomes depending on where the tumor is located and what size it was. So what we hope for when Dr. B is able to do this for us is we hope that even if we have a large tumor, it might shrink away from the center vision. So I've seen children who have these really advanced D and E tumors where it just shrinks completely away from the center vision, and they can end up with 20/20 vision. But sometimes you get a scar that's in your center vision, and you end up with something like count fingers vision or hand motion. But these kids can still have very useful peripheral vision and have really good cosmetic appearance so they can get around and don't have some of the social stigma that might come with having an eye removed.
Pretty exciting stuff.
Dr. B, is there other chemotherapy options that you need to tell us about, or radiation options?
Well, I specialize only in the intra-arterial chemotherapy, but Dr. Dalvin also does intravitreal chemotherapy, which has also been shown to be very effective.
What is that?
So the vitreous, that's a liquid inside the eye. So you actually inject the chemotherapy with a needle into the eyeball?
Exactly. So that's where Dr. B and I really kind of tag team some of these really advanced tumors. So he can do the intra-arterial delivery, but then sometimes I might also give intravitreal delivery. So it's kind of getting chemotherapy from both the back and the front of the tumor. And that can be really effective at saving some of these advanced eyes as well. And several other things we can do to try to save these eyes. This is often a multimodality approach. So it's often not just one treatment and we're done. So sometimes we might see little small areas that need treatment. We can do things like freezing called cryotherapy. We can do things with a specific heat laser called thermotherapy, and those can really treat some of the really tiny tumors so that we don't need to circle back to our chemotherapies even if we have a small recurrence. Other things we can use include radiation therapy. Now, I want to make an important distinction here. In the old days, we used to use a lot of external beam radiotherapy, and this has some pretty serious side effects. So you can actually end up with some kind of dysmorphism of the face. You can stop those bones around the eyes from growing properly. And the other thing is that increased the risk of other cancers forming where we gave the radiation. Nowadays, we have something called plaque radiotherapy, and we use this all the time. We've actually been using it since the 80s in some of our adult eye cancer patients. But this delivers radiation just over a very particular spot in the eye. It's very localized, so we don't get any of that side effect on the bone. We don't see any risk of second cancers with this, and that can be really helpful for some tumors when they're resistant to our chemotherapy.
All right, retinoblastoma, cancer of the eye, unfortunately more commonly affects children than adults, but there are multiple treatment modalities that are available, including intra-arterial chemotherapy and intravitreal chemotherapy.
Our thanks to ocular ophthalmologist Dr. Lauren Dalvin and neuroradiologist Dr. Waleed Brinjikji. Thanks both of you for being here.
Thank you so much for having us again.
Thank you.